I give I give the reasons earlier. My name is Idime Jesse, and I am a 400 level student of medicine and surgery at the University of Jos, Nigeria. And I'll count it as a great privilege to be amongst us and also be here presenting these slides in the presence of my mentor, Dr. Ahmed Abdul Karim. Again, thank you very much, CEF, for giving me this opportunity. And I believe that this session would be a brainstorming one, in the sense that I would also learn from great minds as we discuss this highly important topic. So we'll be discussing improving healthcare system in Nigeria, the way forward. I personally feel that this is a topic that it's high yield for the moment. It's one of the greatest things that we should ask ourselves and put heads together to see reasons why we have great resources and yet we have so many of these issues in Nigeria, such as the healthcare system. So I'll be using just 5 outlines, which the first one will be introducing the topic, and the second will be having the health system, the journey that we've had so far in the health system, right from the independence Nigeria down to this moment. And from there, we'll be discussing the limitations to equitable healthcare delivery in Nigeria. Then we'll talk about the way forward, and would conclude. I'm hopeful that it won't take much time, and by God's grace, we would be able to discuss as much as possible. So, from introduction, the Nigeria healthcare system involves a conglomerate of sectors, structures, and policies aimed at bettering the health status of the average Nigerian and the delivery of health needs when necessity calls. I believe it's not just the healthcare system, it's involving of structures and...
Hello, Jesse. Sorry, am I allowed to come in? I'm not sure whether I'm the only one. I can't see your slide. Like, you didn't click on from the beginning. Is it the same thing over there? It's still showing your first slide?
So resume slideshow. Just go to the top again. Just on top, just showing on your slide, on the first slide, resume slideshow. Press resume slideshow if you can. Right there. Or another thing you can do is if you go to the bottom of your slide, you see that 60%.
Yeah.
Discussion on the way forward. We'll have a discussion on the way forward before the conclusion. So, Sir Mubarak, please, can you move to the next slide? Thank you, sir. So the Nigerian healthcare system involves a conglomerate of sectors, structures, and policies aimed at bettering the health status of the average Nigerian and the delivery of health needs when necessity calls. So I believe that the Nigerian healthcare sector does not only have to do with the hospitals and every other infrastructures that we have to aid for treatment of diseases and others. I feel like policies and also other sectors, such as the sectors that has to do with the environment, the Ministry of Environment and the Ministry of Labor, and a lot of them have 1 or 2 things to do to affect the health status of the country as much as possible. For an example, the Labor Ministry, the workforce, it has a lot to do with the mental health of the average Nigerian, and I believe mental health is also part of what we discuss presently when we talk about health status of the best healthy people. So we also talk about policies and also the structures as much as possible. So it encompasses the mechanism and the dynamics at which the nation, Nigeria, utilizes in maintaining a state of apparent well-being for the average citizenry. The provision of healthcare in Nigeria remains the function of 3 tiers of government. We have 3 structures that has so much. I don't know, can we hear me?
Yes, we can hear you.
Okay. So there are basically 3 structures of the government that, as we know, that have to do with, their function has to do with the maintenance of health of their citizenry. So we have the federal, the state, and the local government. The federal government has a lot to do around the federal medical centers and the teaching hospitals, which that's at the federal level. Then we have the state-owned general hospitals, and I target the cellular primary healthcare centers, right? Because I believe it is from where the basic health need is, right? So that's why I target cellular healthcare centers, which is managed by 174 local government areas in Nigeria with support from respective state ministries of health as well as private medical practitioners. I said 774 local governments does not mean we have just 774 primary healthcare centers. We have even primary healthcare centers in districts, right? So we have divisional primary healthcare centers in some districts of some of the local governments. So, but this is just to give us a broad overview of how the structure of the healthcare delivery is in Nigeria as pertaining to the clinics. So, sir, can you move to the next slide? So this is a diagram that shows what I just explained. We have the tertiary hospitals, the regional hospitals, the district hospitals, the health centers and sub-district, and the CHPS zones. So can you move to the next slide, sir? So the secondary healthcare centers managed by the Ministry of Health at state levels. Patients at this level are often referred from the primary healthcare centers, and this is the first level of specialty service and is available at different divisions of the state. So we have the state primary healthcare Hello?
We can hear you.
Yeah. Okay, the state primary healthcare comprises of laboratories and diagnostic services and also rehabilitation centers. So you have the tertiary healthcare, which is provided, which provides the teaching hospitals. We have teaching hospitals, the specialty hospitals, specialist hospitals. At this level, the federal government also work with voluntary and non-governmental organizations, as well as private practitioners. So can you move to the next slide? So yes, while it is very, very popular to think of healthcare delivery as solely clinical, when we discuss topics like this, it is very, very popular for people to want to digress towards understanding what happens in our hospitals, and a lot of them. But then there is so much that it has to do of the hospital, of the clinics, healthcare to a nation. I believe it has so much to do of the clinics. We have data collection, research, innovations, and the community-centered approach. A lot of them have a lot to do. If we are going to make, I believe if you're going to make the topic of healthcare delivery solely clinical, then we are going to be facing or forwarding our attention basically on treatment and not more of prevention. So if we are going to seriously want to talk on topics like this, I feel that we should have a touch on the preventive approach and also other sectors that has to do with healthcare delivery in Nigeria, the preventive measures to healthcare delivery in Nigeria. And then also, we also have to talk about the clinics as much as possible because they serve the basic function of treatment and as much as possible. But then without, if we are going to maintain good healthcare, then one of the first things that I believe, as a tropical nation as Nigeria, one of the things we should focus is the preventive. So it also encompasses the dynamics at which these sub-segments are synchronized to survey, record, research, and provide solutions to health needs. So it also encompasses the way at which we can synchronize some of these extra clinical sectors of healthcare delivery and make sure that we achieve our main goal, this healthcare delivery. So it encompasses how we can manage data, how we can make sure that there are a lot of research going on, how we can have good innovations, as well as community-centered health approach programs to make sure that we achieve these goals. So, sir, please can you move to the next slide? So the journey so far, healthcare delivery in post-independent Nigeria did take a bullish turn. That there was serious progress being made within the point of independence. I think it's even before independence. So before independence in 1960, there was a 10-year development plan between 1946 to 1954, which was introduced to enhance healthcare delivery. It was then we had several health schools and institutions, Ministry of Health, several clinics and health centers that they were all developed in accordance to this plan. So within this moment, we had, I can say that this was the peak of healthcare delivery in Nigeria. And while we go through the whole slide, I would want to explain the reasons why, or when we are talking about the limitations to healthcare delivery, I believe we can actually use this as a focal point in our discussion, because this was the moments where we had the administrations of Nigeria. This was the moments where we had the administration of Nigeria not held by the indigenes of Nigeria, and yet we had good healthcare delivery. So, sir, can we have the next slide? The consequence to this plan, the wake of the 80s introduced a great development in healthcare initiatives. So I made healthcare initiative, not the real healthcare. There was a lot of initiative that was brought in the 80s, right? So we had general hospitals and several health centers. Over 10,000 of them had been introduced before that moment. So we already had these general hospitals. We had health centers and a lot of them before this moment of the 80s. But then in the 80s, I believe from the 60s down to the 80s, there was a decline in health delivery. There was a decline in health delivery, and then that was the cause for some of these initiatives that was brought in the 80s. And I believe they were very perfect initiatives from what I have here. So, sir, can we have next? So they were to facilitate good management. Okay, to facilitate good management of this positive trend, the federal government launched a primary health plan that had the following goals. The next, the goals were to improve collection and monitoring of health data, to improve personnel development in the healthcare, to ensure the provision of essential drug availability, improve on immunization programs, promote treatments of epidemic diseases, improve food supply and nutrition, improve maternal and child care, I guess that's maternal, and child care and family planning, educates people on prevailing health programs and the methods of preventing and controlling them. So if we look at these initiatives, you can't say that this is actually a very nice initiative, and you would be very, very positive at what this initiative would give us. But okay, sir, can we have the next slide? However, this plan made little impact in the sector as there were personnel deficits, poor public health management, and infrastructural deficits, and hence led to the progressive decline in the health states of Nigeria in the 1990s. So one thing I would like to comment is it is very okay. I believe it is very, very okay to make initiatives, to make plans, to make goals, we just entered the new year, and it's very clear that a lot of us must have written goals and things that we want to do. But it is something to maintain those plans, to also go with those goals as much as possible. Then we had this goal, but then the issue was that we were not able to move in accordance to this goal and these things that we have planned, even though there were nice initiatives. So then all this, with the whole increase in population and increase in rate of poverty, and as well as other factors, led to the decline in health state of Nigeria in the 1990s. So I believe that the population of Nigeria as at then was increasing, and then the economy of Nigeria was not increasing with the population of Nigeria. And we know what happened when population increases, and then there is no resources to buffer for that increase in population. They come to a state where people live like we have people living below the poverty line. A state where I believe people live in poverty, and we understand that with poverty comes a lot of public health challenges, such as the tropical diseases, as much as possible. So, sir, can we have the next slide? So this is a graph that shows the progress of under 5 child mortality rates from 1964 to 2017, and life expectancy at birth from 1960 to 2017. So if you can see this graph, I like to think that there was an initiative between 1980. So that was the reason why we had a testing. I think there's testing in the graph between 1980 to the early 90s. And then from then, when there was no, it was clear that there was no real management of this initiative. There was nothing to be said about the full maintenance of these plans. Then we had the whole bearish move from the early 90s down to what we have at the moment. So it is okay to make initiatives, but there are a lot of factors. There are a lot of factors that makes these initiatives wouldn't really be accomplished. A lot of them will be discussing as we go further in this slide. So in an effort to improve the state of health in the 1990s, that is after the whole plans in 1980 didn't work out, the Nigerian Health Insurance Scheme, NHIS, was established in 2005 by Decree 35 of 1999, which provided for the establishment of a governing council with the responsibility of managing the scheme. So this scheme was established to improve access to quality and affordable healthcare for all Nigerians. Since for a fact, there is increasing population, and we all understand about the economic outturn from 1960 to the moment. So it was an initiative. This is also an initiative that was brought, and it was meant to improve access to quality health as well as affordable healthcare. So we would be listing what these initiatives would plan to achieve. So it plans to ensure that every Nigerian has access to good healthcare services, to protect Nigerians from financial burden of medical bills, to limit the rise in the cost of healthcare services, to ensure equitable distribution of healthcare costs among different income groups, equitable patronage of all levels of healthcare, to maintain high standard of healthcare delivery service within the scheme, to improve and harness private sector participation in the provision of healthcare services, to ensure adequate distribution of health facilities within the Federation, and to ensure the availability of funds to the health sector for improved service. So if we are going to look at this whole aims, this whole plan, and these whole things that the NHIS plan to achieve, we would see that it is planning to be symbiotic, in as much as the federal government or the government is going to see that there's going to be funds to have an improved healthcare sector, for also an improved service delivery. The normal and average populace would also have access to good healthcare, right, without financial burden of serious medical bills. So this was actually also a great plan. So the objectives and functions of the NHIS, according to this present review, have hardly attained any height as healthcare delivery continues to be limited, not equitable, and does not meet the needs of the majority of the Nigerian people. This is indicative of the high infant mortality rate and poor maternity care, very low life expectancy as at 2010, and the periodical outbreak of the same diseases, as well as the long period of time spent to control these outbreaks. So if you would look at the plan from 1980 down to the point of NHIS, you would see that all the issues that would be happening in Nigerian healthcare sectors within the 2010 to 2015 wouldn't be there, right? So it shows that we had initiatives, there were good initiatives that were being brought up, but one or two things must be lacking. And those are the things we'll be talking about in the limitations. But one or two things must have been lacking, and that has not been able to make sure that the federal government or the government would maintain some of these initiatives and some of these plans for the healthcare sector. So this shows the statistics of the birth rates, the death rates, and some of the prevalence of diseases. HIV deaths, HIV prevalence, and life expectancy was 47 years as at 2010. So if we look closely to this, we discover that we shouldn't be having such statistics again at 2010 when these initiatives has been, if we had good good use or good, if the initiatives had been met or the plan had been met, this wouldn't have been the statistic that we'd be having as at 2010. So we can say that the Nigerian healthcare system has for long been just bringing up good initiatives without proper execution of such initiatives. So can you move to the next slide? So now we will talk about the limitations to equitable health delivery in Nigeria. So we shouldn't shy from the fact that like the normal political movement that happens in Nigeria, good manifestos, and at the end of the day, we are going to have poor outcomes of leadership and service. So this is actually some of the things I feel have been one of the limiting factors to the execution of some of the plans that we've had over time. There have been corruption, there have been political instability. I think within the 90s, there were serious of the political instability, I think really seriously thrived within the 90s. So there have been serious corruption, there have been unstable economy, there have been lack of modern facilities, and the Nigerian healthcare sector has not really been able to evolve in accordance to the world healthcare delivery sector. So there have been lack of modern facilities, there have been personnel shortage, definitely. I think this is relative to corruption and political instability. If we're going to have corruption and political instability, definitely affects funding, which we have here, poor funding. It's going to affect funding for some of these initiatives, right? And with poor funding, we would have a reduced work environment for Nigerian healthcare personnel, right? And with that, it is very, very necessary for us to have shortage of such personnel, because definitely, like a lot of my mates will say, you don't expect me to kill myself and work in Nigeria for 12 hours and at that long amount and be earning as low income, and then when I can go to somewhere I would have good environment, good work environment with good ethics and everything, and be earning better. So that is one of the things that causes the personnel shortage. And if you would notice, you see that all these things are interrelated. All these things are interrelated, but the first of them is corruption. The root cause of it is corruption and political instability. corruption, political instability give rise to poor funding. Poor funding give rise to lack of modern facilities. Same poor funding is going to give rise to personnel shortage. And also when we have reduced management structure, when we don't manage from political instability, we don't have good representatives. We wouldn't have necessary policies that would aid for interoperation in the healthcare sector. What I mean by interoperation is where we have doctors, nurses, med lab scientists, science lab technologists, and everybody working together to achieve a specific goal in the clinics. So that's what I mean by interoperability. So yes, I can move to the next slide. So insufficient insurance coverage and unappreciable remuneration and workers' welfare, like we said in the poor funding. So these are the definite, you can't, especially the last one, unappreciable remuneration and workers' welfare. So in the course of in the course of this slide, we would be, there is a session where we would be having a discussion on the brain drain and also doctors leaving Nigeria. So I believe, on my own personal view, that this has a lot to do with the shortage of personnel that we have, workers' welfare, unappreciable remuneration. Recently, there was an incident that happened in the, I don't know, I didn't really follow the news, but it made rounds everywhere on my status and everywhere, of a patient relative that killed a doctor due to some, I don't know what really happened. But then these are one of the reasons. Removing, putting aside unappreciable remuneration, the work ethics in Nigeria, the work environment in Nigeria as a medical personnel is not something that we can write home about. It's very, very poor. We see daily house officers, we call some of them, they are being called house boys here. So you will see how they work from morning to night, down to morning, and then it is not just the pay, but you don't expect somebody to be productive with this kind of schedule. So there's something on the workers' welfare. Then insufficient insurance coverage. So we already have the NHIS, but that doesn't, we all understand that from corruption, we have the lack of coverage of some of these initiatives, such as the NHIS. So sir, can you move to the next slide? So we'll talk about the way forward. The first here, okay, in the way forward, we'll be looking at what can we do? So if we are going to have some of these problems, we are going to have, definitely there's corruption as one of the leading causes of what we have in Nigeria, limiting the healthcare coverage in Nigeria. We have political instability, the shortage of personnel, and the rest of them. So we want to discuss what can we do, or what should the government do, what should communities do, what should organizations do to make sure that even while these problems thrive, even while we still have corruption, right, even while we are still trying as individuals in Nigeria to make sure that we orient people to understand the effects of their political decisions, what other things should we do or can we do to make sure that we have good healthcare delivery in Nigeria? So number one, we need to strengthen community involvement. We need to strengthen community involvement, because at the cellular level of healthcare in Nigeria, where we have the primary healthcare sectors, we have a lot of things happening, right? So let's have communities must be galvanized and possibly incentivized by state governments to be more involved in the upkeep of their primary healthcare centers and ditch the idea that government must do everything. Improved community engagement could start by communities setting up an endowment fund for their primary healthcare centers, which should be funded by levying themselves or conducting fundraising events, right? So there is need for us to strengthen communities. And in one of the ways we can strengthen communities is we would also discuss on one of the ways we strengthen community involvement in healthcare delivery. We, even while the government is going to be doing
hello Edime. Yeah, sorry for cutting you short. Just to let you know that you need to wrap this up in another 5 to 10 minutes. We've been on this presentation for close to 30 minutes, and I think we need to wrap this up in another 5 to 10 minutes so that we can go to all that things like commentary and your mentor's contribution. Is that okay?
Yes, it's very okay.
Thank you.
Okay. So, like I was saying, we would need to involve the cellular bodies, the primary healthcare centers, to be involved in maintaining healthcare delivery. And some of the ways is, like I discussed, conducting fundraising events and the others. So can we put the next slide, sir? So you need to continuously train primary healthcare workers. So I think we should move to the next slide so we can. Okay, formalize relationship with referral medical centers. In this one, we would be having state governments. The state healthcare centers should have good relationship with the primary healthcare centers, so that we wouldn't be having issues with referrals from the primary healthcare centers to the state-owned medical facilities. Sensitization workshops for local government and council leaders. I believe this is very, very important because if we look at a lot of things that happen in the local sector, there are a lot of ignorance that happen that we have presently, especially number one is the bone setters. We understand that a lot of times the bone setters are actually bone destroyers. So there are a lot of ignorance that we have in the local level of healthcare. We see a lot of drugs, a lot of local medications that we give for certain diseases that are not meant to be so. And at the end of the day, we are going to cause serious health issues to the person involved. So some of these sensitization workshops are very necessary. So can we go to the next slide? So we need to mandate, verify, and enforce a minimum level of spending on health. Very, very necessary. There should be policies that should stand and say that, okay, we are going to spend 20%, 15% of our budget on the healthcare sector. Okay, even though we have had such policies, we still need to make sure that we have continuous policies like that to make sure that there is something that they say that when you keep hitting a hammer on a rock, if you are continuous, you're going to have a change. So it is very necessary that we are going to that we have a minimum level of spending on the healthcare sector. So can you move to the next slide? So yes, the big picture, we need to emphasize public health principle in schools. So we need to, if you notice, most of these things I've been saying is at the cellular level, because if we are going to really put aside corruption and the other things, we need to make sure that at the cellular levels, there are one or two things that we are doing to improve healthcare delivery, even while we understand that corruption is thriving in Nigeria and there's still political instability. So we need to emphasize public health principle in schools. As 3 months ago, I in my office in NIMSA, we were trying to have to make sure that we have NTD club and societies in schools in Nigeria. We wanted to make sure that we have close to 100 schools in Nigeria having this NTD club and society. What was the basic goal of this? The basic goal of this is to make sure that we are going to establish a council, like we're going to establish a committee of students who would find it necessary to learn and also spread the news on public health and also hygiene and other things that would aid good well-being, and that's good health. So, sir, the next slide. A public health program should also be included in school intra and extracurricular activities, like I said, such as club and society committees and leadership councils, such as the student representative councils. So computerization of operations, it is no doubt that we are already evolving. So we really need to evolve with the time and make sure that we have the inclusion of ICTs and other things in our healthcare sector. So the next slide. So definitely, we can't, even while I've been trying to see how we can put away the topic of poverty and economic instability, I don't think that we can fully put it aside because it's at the center of a lot of this, of most of these activities. So the plunged economic state has so much contributed to the health state of Nigeria that if we are going to have 49% of people living below the poverty line, I don't think there is any way we are going to have an improved healthcare delivery in Nigeria when these people are definitely not going to have good water supply, they're not going to have good hygiene and a lot of other things. So we really need to look at the root cause, which is poverty and economic instability. And we already understand that Nigeria is, it's a paradox that Nigeria has so much wealth and we are still very, very poor. And one of the basic for that is the fact that there is serious corruption in Nigeria. So, sir, the next slide. The next slide, sir. So hence, a change in the status quo begins with a change in the root cause, which is poverty and economic instability. That's what I just said. So the next slide, sir. So I think it's after the post schedule would discuss this. So the next slide. So telemedicine. Telemedicine involves the remote delivery of healthcare services, including exams and consultations over telecommunication infrastructures. So telemedicine allows healthcare providers to evaluate, diagnose, and treat patients without the need for an in-person visit, right? So in trying to, this initiative is an initiative that has for long been in use in a lot of organizations like WHO, UNICEF, and some of them. Some of them have tried to make availability of some of the telecommunication infrastructures to primary healthcare centers to make sure that they bridge the gap between primary healthcare centers and the tertiary healthcare centers, such as the teaching hospitals and the rest of them. So telemedicine uses some of these infrastructures. Some of them are the laptops that we are using, the phones, and some of them are some of the things that we use in telemedicine, right? So, start the next slide, please. So we need to support students and non-governmental organizations if we are hoping to improve healthcare delivery in Nigeria. I included this because
sorry, Edime.
Yes, sir.
Yeah, if you just go with the headline so that you don't do detailed explanation of the slides going forward, because we are way past the time now, you understand, and we need to have some discussions. Thank you.
Okay, I think we're almost done. Yeah, we're almost done. So this is the last slide, sir. So this, okay. So we're talking about the student involvement. It's, we need to make sure that we have organizations, when students come up with some of their initiatives, they want to make outreaches and some of the things like we have the Nigerian Medical Student Associations, all the student associations that we have, we discover that some of these student associations are able to reach out to the cellular level of these healthcare deliveries. So I believe that they should be enforced as much as possible to take on such tasks. So in conclusion, improving healthcare delivery in Nigeria is by far not an Herculean task. The sector, just like other sectors, is only suffering in the hands of what can be nicknamed as Nigerian effects: corruption, zero prioritization of budget in budget allocation, selfish public service, poor political orientation of the populace, and a myriad of other activities which are lethal to our constructive growth as a people. Hence, it is incontrovertible to posit that Nigerian health system suffers from a maladministration syndrome, and the best way to change the status quo is through electing good leaders, political sensitization, and holistic electoral processes. So I think that's the end. So the only discussions schedule there is on the brain drain. So I think that's the end of.
Thank you. Yeah, sorry. Once again, can I ask you if it's okay? What's the first name? Is it Jesse or Edime? Which one would you prefer me to call you?
My surname is Idime, but I prefer being called Idime, sir.
All
My
right.
first name is Jesse. My surname is Idime, then my name is Jesse.
Okay, I'll go with what you prefer. You prefer to be addressed as Idime, is that correct?
Yes, sir.
All right.
Yes, sir.
Thank you, Idime, for the wonderful presentation. I think you covered almost everything. Yeah, I agree with your outline. It's well laid out. You started with introduction. You went to the body, which covers very important things, and then your conclusions were also succinct. I think I agree pretty much with everything you've said. Yeah, so just to create a quick summary of it, then I'll allow your mentor to have a robust discussion of what you've said. From there, maybe we'll give him like 10 minutes to have a robust discussion, 10 to 15 minutes rather, to have a robust discussion on what you said. Then if he wants to have a second go much later, he can have another go much later when we open the floor to the other floor members. So after your mentor's contribution, we'll move on to the contribution of members. And I think this is a very important topic. This is a topic that touches almost every one of us. At one point in time, we will need to seek healthcare, and the it's very important for us to know the challenges and where the problem lies, where the problem is, and the kind of solution that we need to prefer. So I will enjoy all of us to listen to the other part of this presentation. I think they are as important as this presentation itself. The contribution for all the our members will go a long way, in adding beauty to this presentation. So then after for people that are interested in going for the second round, in another 10 to 15 minutes, we'll do that. Then we'll conclude and give a closing remark. I hope that's okay. Just a quick review of the presentation before I allow your mentor to give us a robust, touch to what you're giving. So I agree with your outline. I think they are fine. I think you've done very well regarding the presentation. There are a few things I think you should have mentioned that you didn't mention, but at some point you did actually mention some of the components. I didn't see things on universal health coverage, which I think is very important when we are discussing healthcare at any level, because what universal health coverage says, that will really give a succinct understanding. It will make everybody here to really understand what we need to do and where the problem lies and where we should be focusing, in addressing our problem. So that's something I think is missing in your presentation. Of course, you did mention some component of UHC, but universal health coverage itself, I don't think we'll do justice to this topic without mentioning UHC. And that's the reason why I said I should just highlight that. Very importantly, you've divided health sector into three. I agree with the division, the primary, the secondary, and the tertiary. And you did, in the context of Nigeria, let us realize that we have a federal parastatals that take care of some. We have the states and local parastata that takes care of some. More often than not, majority of the teaching hospitals being looked after by the federal. Just for simplistic sake, the general hospital and the is being looked after by the states by and large, and the local government is meant to look after the what you call the cellular or the primary level. So that's just a simplistic division, but it will be very important. It's very important to mention this in Nigeria healthcare system today. If you don't mention NGOs, the like of MSF, the like of UNICEF, the like of USAID, the like of WHO, I don't think the topic is complete. So I like the fact that you did recognize the contribution of the NGOs and the private institutions, in our health system. I think going to state like Zamfara, going to state like Borno, all those IDP laden states. In fact, close to 60 to 70% of what is happening there is actually covered by these NGOs, because we have colleagues in there. They are the ones that are actually doing the job. Majority of this local government, the healthcare, the PHC, the primary healthcare centers in all these local government, people cannot even get any health from those things, or any care from those places. So majority of the care that people are actually getting from in those zones are actually from these NGOs. So I think, especially from the northern axis, the north central, the northeastern side, and the northwestern side, the contribution of NGOs is actually very, very huge. I would say almost 65 to 50 to 60% of what's happening at the primary level. So it's quite important that you did mention that. And one of the things that we need to really, really, emphasize on that we are not doing, you mentioned things on research, things on health education and data management, which I know that at some point somebody will also made mention of it, because we have a lot of things to discuss on that. So you proceeded into mentioning a few things that I actually agree with. I think I like the outline when you divided the journey so far, what was happening pre-independence, immediately after independence, 10 to 20 years after independence, we had some remarkable achievements, and from 1990 downward, everything takes a very deep, in the healthcare system. And you did let us know the reason why the whole thing had a poor tone. So I think that's very important. But there was one that I didn't really agree with. I'm not sure whether everyone here has a diverging opinion from what I want to say. You did mention at some point that you think the dwindling resources, sometimes around the 90s or the early 2000s, is the reason why our healthcare system did suffer a massive decline. I think I beg to differ. I don't think I agree with that. I don't think it's really resources that's the problem, rather mismanagement. I think you and I know about the oil boom, sometimes around 2005, sometimes around 2008, especially 2008 to 2012. Nigeria, just like the way Qatar has made the money, the way Saudi Arabia has made money, the way Russia has made money, we made huge amount of money. I mean, there's something on excess crude account and all that, and no one still deemed fit, to use this money for something good. This money were unaccounted for. This money was stolen, and there were a lot of debate about how the money were spent in the public space injudiciously. So I really don't think it's because of the resources that's dwindled. That's the reason why we suffered a decline. I think it's just Nigerian being Nigerian, it's just the part of the problem that we're having. So the massive, that's responsible for the massive decline. So you did mention NHIS. NHIS, I don't think we can talk about healthcare system in Nigeria and solutions to it without mentioning NHIS. You did say that a good number of Nigerians are poor, which I agree with you. We have a good number of Nigerians, I would say almost like 60 to 70%, of Nigerians are not meeting the WHO requirements, So we're really, really poor. But what can we do? What poor countries like, around the globe that have managed to have something presentable in terms of their healthcare system, what have they done? If you look at the solution, you will know that everything lies on primary care. And when you discuss primary care, there's nothing we're discussing there more than NHIS. You need to take from the rich to cater for the poor. And that's the essence of NHIS. But unfortunately, what we have in Nigeria is not NHIS. We've had before, in which those people that are even trying to save the system, they force them to resign, they chase them out of the system. I can remember the popular Dr. Yusuf that was trying to fight the system and trying to salvage the system. He was trying to fight those people that are trying to loot the system, and he wants to recover the NHS and the NHIS. But unfortunately, for some reasons, he had to resign because there were issues bubbling around corruptions and all that. So NHIS would have given us a perfect opportunity right from 2005, enroll people massively so that people can get access to primary care. But unfortunately, what we have today is not NHIS, it's not even close to what NHIS should be. But I will allow others to make comment on that, and much later, when I have my second go, I will talk much on that. I just want to give us a quick recap, and our time is fast spent. So I would like to have a few words on universal health coverage. I'm not sure whether your mentor will also have a few things to say about it, but just if you guys could permit me, let me just mention a few things about universal health coverage, then I'll draw the curtain on my quick wrap up, and then I will allow your mentor to have his own goal. So universal health coverage, ideally, almost 2 billion people at this moment are facing catastrophic or improvisation spending. And there's a massive inequality that continue to be a fundamental challenge for universal health coverage as aggregated data marks within country inequality in service coverage. And what has not helped is actually COVID-19. COVID-19 pandemic further disrupted essential services in 92% of the countries, meaning that almost all the countries in the world are actually suffering for one problem or the other. And if you look at it, even the likes of United States, the likes of United Kingdom are not also immune. COVID-19 has not really helped situation at all. So to build back better, what WHO actually recommended is to reorient health system to primary health care. And that's where I'm going to. Most 90% of essential UHC intervention can be delivered through primary health care. And 75% of projected health gains from SDGs could be achieved through primary health care. So I think I would like us to make emphasis on primary health care today. What can we do in terms of restructuring, in terms of changing things, in terms of devolution of power, in terms of improving political will to ensure that at the level of primary health care, the PHCs are revived and all that, so that we could have, we could be able to meet our SDG. So that would be the short recap that we'll be having on your presentation so far. I might have left some things deliberately. I'm sure your mentor will pick some of them up. But by and large, I think you've done a wonderful job. I think you had a very good presentation. Some of those slides looks a little bit wordy. I would prefer them to be more bullets, to be presented in more bullet form, like a conclusion, and you can just make it like 3 bullets rather than you having it in words like that. So, but by and large, I think it's a good presentation. I think you address the major problem in terms of what the problem is, and I think you've given some solutions. Some of those solutions I've not talked about them. When I'm having my second go, I think I'll mention what I think what I think we should focus on in terms of solution. So once again, I thank you on behalf of the Champions Educational members. I thank you for the wonderful presentation. Over to you, Dr. Ahmed.
All right, Dr. Mbarak, thank you very much. I would start by thanking Edime for the wonderful job in presenting this topic, which is quite broad. It's difficult to have a session to discuss the healthcare system in Nigeria extensively. So we understand why you have problem with the time constraint. I would also thank Dr. Mbarak for an excellent moderation and bringing insight and into it from different angles. From the universal health coverage angle, from the access angle, improving access to healthcare, from primary healthcare, from the what's it called again, the NHIS itself that we are having in Nigeria and how it's been structured, and it's been a wonderful moderation. So I would stand by agreeing with Edime that when we talk about health is a complete physical, mental, and social well-being of every individual, and not merely the absence of disease and infirmity. You understand? So when we oftentimes talk about physical health and neglecting the mental health of people, a lot of people going about with the mental health problem, and we just pay lip service to it. And even social, when people don't have a place to live, when they think about how to make three square meals, that predisposes them to immunosuppression, and that also predisposes them to poor health. So eventually, it's a cycle that continues like that. So, but limiting it to the topic of today, which is improving healthcare system in Nigeria. So when we say we want to improve something, it means there are problems. So that is a problem. That's a point. So it means there are problems. And one, I'll divide my discussion into one to talk about the problems in the healthcare system in Nigeria at the moment, and then I would delve into the possible solutions, the way out. So first thing, is the limited access to quality health. So that's number one. And although we know we have primary, secondary, and tertiary health care, primary health care being the community at the community level, secondary the generals, and the tertiary the teaching hospitals. But are people actually having access to quality education? Nigerian population of over 200 million. How many of Nigerians actually have access to quality healthcare? Up until today, there are communities, there are communities in some local government that do not have a single primary healthcare center. So how do you expect them to deliver? Women still deliver at home and still have maternal mortality and perinatal mortality. Children fall sick and die of preventable illness because of poor access to healthcare. You understand? And even the ones that are available, they have shortage of healthcare professionals. So the healthcare professionals are there, are very short. And when we talk about healthcare professionals shortage in Nigeria, we talk about doctors, nurses, lab scientists, and every other person that contributes to delivering of good health. In the moment, the current statistics is about having 4 doctors to 10,000 people. That's if not worse in Nigeria. So that's shortage of healthcare professionals. That's what we're talking about. So average of 4 doctors to 10,000 Nigerians. So how do you want to provide quality healthcare in that situation? It's almost impossible to do that. So, and then even the healthcare centers that are available, they deliver poor quality of care. And when we say poor quality of care, it's not the fact that the nurses and the doctors are not competent. It's because they use outdated equipment and then the inadequate training. Some people, the last thing they know was in medical school. The last thing they know was when they were in school of nursing. No training and retraining of staff, no updating of knowledge, no guideline, nothing. So how do you expect quality healthcare to be delivered in that situation? And then high out-of-pocket cost of healthcare. So oftentimes people pay out of their pocket, and when they cannot afford that in a country that has 60 to 70% of the population that are poor, some people just stay back at home, die of things that are preventable, and because they would rather do that than going to the hospital because they know they can't afford it. The government hospitals are overpopulated. The bureaucracies there are much. There are no equipment. You get to a teaching hospital, a tertiary hospital, and there are no oxygen cylinders. Patient has a myocardial infarction and cannot be catered for. No cath labs, nothing. So how do we deliver quality healthcare in these instances? So, and we're talking about out of pocket care. So when you have 60-70% of the population poor, then you realize that there is no way they can afford quality healthcare without government doing something. So the financial hardship will contribute to that. And then largely, another thing is lack of government funding and investment, which would contribute to many of these problems that I've highlighted. And when we talk about lack of government funding and investment, it might seem like, okay, no, just the common sense. The 2023 budget that we're reviewing at the board level recently, the federal government budgeted 1.58 trillion to the healthcare sector in a budget of 20.5 trillion. But even when you think 1.58 trillion is about 4% thereabouts, of this 1.58 trillion, 1.41 trillion is on expenditures, recurrent and capital expenditures. So you're left with barely 400 billion or so to do infrastructures for immunization and for basic health provision fund. What can that do in a year for a population of 200 million? And it is in this same budget that you have bureaucracies, agencies, And you have agencies, bureaucracies, and institutions, having duplicated functions that have been marked with hundreds of billions. So cost of governance is quite expensive in Nigeria. So, and there is no priority for things that are important like health and education. So these are the things that are the problems that are currently ravaging our healthcare system. But it is important to know that the healthcare system does not occur in isolation. For us to have a good healthcare system, we must have the ministries of education, the Ministry of Environment, the labor. Our institutions must be upright. Justice, there must be monitoring and evaluation and stuff like that. Because when we get to solutions now, I would like to adopt the method that Idime also adopted. One is preventive medicine. We shouldn't wait until people fall sick. We should invest heavily in preventive medicine. And how do we do that? He mentioned some things, which include data. We first need to know how many people live in a place, how many people live with a particular disease, how many people are elderly, what is their peculiar needs, children under 5, what's their peculiar need. We need data, and then you can target them. Vaccines. We need vaccines, as part of preventive medicine. Also in that budget, barely about 90 billion was budgeted for vaccine. Rwanda during COVID-19, they set up a lab and they manufactured their own vaccine to deliver to their people. Nigeria we're still putting hand out to international agencies and donors to give us vaccines. You understand? Given our potential and our resources, you understand? So of course you can get paid, but you have to do something. So vaccination as part of preventive medicine, research into our peculiar diseases and our ailments and our population, and then having data that is peculiar to our population and ourselves, and then education. Like we said, health sector does not occur in isolation. An educated population will definitely be a better informed population and live healthier, and that would prevent some things that would ordinarily have happened. When you are educated, there are some things you would never do. You would not be involved. The quality, your water, the food, your hygiene level. Your self-care, your physical and health care, even sexual health care. So someone that's educated would possibly know that it could cause some sexually transmitted infections, and if not properly protected, and that would prevent some diseases and some morbidity going forward in future. So, and apart from that now, so not talking about the problems that we have highlighted, I would also divide it into two, like I said, the cellular level or the primary level and the systemic level. Although I want to say when there's systemic problem, it is difficult for us to have effective cellular solution. So we really need a systemic solution, a systemic overall of the entire system. And I will start with funding and end with funding. But above funding is institutionalization of the system, of the healthcare system and all other systems in Nigeria. Because again, the healthcare system does not occur in isolation. For instance, if you put proper funding into healthcare system, and even the little funding that have been put into it since inception, if they are well executed, we would not be where we are now. So some people just dwindle the money, put it into their pocket. They see every budget here, they see it as raining days. They cash out, go back to their hibernation, and come back whenever the budget is out again. So there's no monitoring and evaluation. People do how they like, and nobody talks, nobody cares, as long as their back is being robbed. So to talk about the cellular solutions, like Idime has said, it goes back to the community involvement, primary health care, community ownership, training of staff, referral system, sensitization workshop for local governments, public health principles, reducing poverty, and again, reducing poverty does not lie with the population. It lies with the government based on the policies they make, the economic policies, and the leadership that they provide. Also, the responsibility of NGOs, civil society organizations, and other organizations like us, educating the population, and like Dr. Mbarak rightly said, the MSF, the UNICEF, the USAID, they have a role to play, you understand, and they could they could also, they've been playing their own role. Maybe their effect would have been felt better if we have the systemic problems solved. So what has contributed to this is, one, corruption. And instead of having a working system, we have an institutionalized corruption in Nigeria. And honestly, if you ask me how do we solve that, I don't know. But that we just really, really have to have people that deliberate and sincere leadership. You understand? Because we have people that got into position of leadership who are not prepared. They are not ready, and it's difficult to think that they have any interest of population at heart. It's just about their pockets, about being praised, about being in that position, about being tagged with that position without anything to show for it, without impact. And you wonder how a nation can actually progress that way. So there's also no poor political will, not only in health, also education, also health, education, security, and all other aspects of life, you know, and also and inadequate funding. We've talked about inadequate funding. So to talk about access, we need to improve. I'll take one of the problems one after the other. Increased access. So the access we have to go back to the primary health care, and a lot of these medical problems and health problems, health challenges can be prevented at the primary and possibly secondary level without necessarily burdening the tertiary institutions. And if the primary health care works properly, one would see how effective it can be. We've seen systems where most 50 to 60% of the problems are dealt with at the primary health care level. So take, for instance, if you take Kwara State, for instance, you have 16 local governments. In each local government, you have what? So if you have working, equipped, staffed primary health cares, you understand, in this local government, maybe 3, 4, 5 in each local government, and you put them catchment area. If you are living within this area, this is the hospital you should go if you have any health challenge. And they are trained to triage. They know what to look for. If this person is something they can treat, they treat them. And if it is something that needs to be referred to secondary level, it goes to the secondary level, and then it's treated at secondary level. So but if every state in Nigeria, every local government have primary health care centers that are attached to a particular area, zones, and they know that if people living in this area are sick, then this is where to go, they would go there, and there are staff that would triage them and know whether or not they should be treated there or be referred to the next level of care. And secondary level of care are also equipped with what they need. Tertiary, the same thing. So it's not a tertiary hospital that does not have oxygen, that does not have transport system, that does not have lights. You're in the operating theater and you're wondering whether they will take light or not. You have to beg the generator house to put on generator for you to operate. And it is really, really disheartening. So implementation of the universal health, invest in training and retention of healthcare professionals. So healthcare professionals has to be incentivized to stay in the country. So if you know that it is a priority to you, this health, you want to deliver this healthcare, then you definitely have to invest in their training. They will have to see personal development, professional development, and also to be to give them a way, retain them within the country. You have to find a way to retain them within the country, so that that will solve the problem of the brain drain. Because it is when you work in a place like Nigeria and you have colleagues working in other places and you see the difference, the level of operation, even before you talk about the pay, what your colleagues, people that you are part can do to pay for patients in terms of healthcare delivery, and you know you're capable of this, and you are incapacitated based on available resources and equipment, and it is disheartening, it is depressing. So, and then to talk about and the pay is also another very important aspect of it. So it's also another very important aspect of it. So the government have to prioritize health and find a way to train healthcare professionals and find a way to retain them within the country. So upgrading equipment and infrastructure is another thing. Implementation of the universal healthcare coverage. The national health insurance system, which you know, if you read on paper, you realize that Nigeria is a very good country on paper. You know, we have all these policies, initiatives that if you read it on paper, you will feel this is a fantastic country. But you and I know what the NHIS is like. Okay, instead of serving the poor, it is actually serving the rich. people in Abuja, people in Lagos, people that are in top echelon, they and their families are actually covered within the national NHIS, within the health coverage. People that can actually afford out-of-pocket healthcare are the ones that are benefiting from NHS, and the poor people in the local in the locality cannot afford it. I have been in an hospital where a mother brought a 3-year-old child with severe malaria. Could not. We brought drugs. Go and buy this. Said Megida as well. Like the husband is coming from home, and before that happened, the child died. She bagged the child and took the child back home. In Nigeria, that is the country where you are, and somebody is sitting up there and does not come on. So we really, really need to talk about this. One, taking healthcare back to the locality, and two, investing in it properly, and three, the national healthcare coverage must serve the poor and not the rich. You have to take from the rich to serve the poor, you understand? So the rich can actually afford to pay out of pocket. Not everybody can do that. So that people know that if they are sick, they don't have to pay anything. All they need to do is just take your child to the hospital and they will be catered for. If you cannot make it free for everybody, every child under 5 should have a free healthcare coverage, or every child under 10, whatever it is. Let's do something for these children and save their lives. So then increase government funding and investment in the healthcare. I will stop here for now, so as to allow other people to comment. But again, it's a very important topic that we cannot exhaust within the time frame given for this presentation. But I think we can mention some things that are very important, and hopefully our voice can be heard and we can contribute to the narrative. Thank you very much.
Thanks, our Honorable Board Chairman, who doubles as Dr. Idime's mentor, or Idime's mentor today, sorry. Yeah, I think he has touched everything. Virtually my solution, whatever I wanted to say, or I was planning to say, is touched like 70% of it. So, which is a good thing, and that will save us some time. So he mentioned something very important. WHO 1:600, our own 4:10,000. You can just imagine the ratio. That's absolutely unacceptable. Yeah, he mentioned poor quality of training. He mentioned institutional reforms. I mean, how many times have we talked about institutional reforms on this platform? That is the major problem. And we just have to go back to the drawing table if you're to, if we means business, we need to go back to the drawing table and reform the institution. Political will, I mean, there's virtually nothing you could do without political will. He mentioned political will, which I think is very essential. And of course, he has touched the main thing, the core of UHC, which is the emphasis on primary care. Under 5, maternal mortality, perinatal care. This is something that any serious country cares about. In developed countries or any other country that are very serious, for people that have had a pregnant wife before, or they've had infant or a neonate, or even any under 5 kids, you could only imagine the kind of attention that is being paid to these people. I do say, maybe for instance, the UK, before your daughter or your son reaches the age of 5, I think he or she will probably must have been seen by a healthcare visitor close to 50 to 100 times. If I'm not exaggerating, yeah, to see the level of care that they do give. So you can see how important this is. And he did mention the NHIS, which unfortunately should be the rescuer, but unfortunately, like he said, they are now using NHIS to enrich the rich. While I was in Abuja working for one of the private hospitals, I did remember that our very own, how would I call it, director, they did like end of the month, 2 months or 3 month time, because that is when they make money from this NHIS. We call them the HMOs. What HMO does is they are like the intermediary between the hospital, the private hospital, and the government. So they collect the money from the government, and they are to remit the money to the private hospital. So what they do is they will tell you, see, for every anti-malaria you prescribe, we can't afford to pay more than 50 naira or they can say 200 naira to say the least. So whether the anti-malaria you want to prescribe, it doesn't matter the quality, they will not give more than 200. And they will tell you that we call it capitation. For every patient that is registered under you, we can't afford to pay more than 2,500 for every 6 months. So even if the patient were to sick and you had to admit the patient, they won't pay more than 2,500. So what the private hospital do is, which irrespective of what brought you to the clinic, will always find a way that your bill doesn't go beyond 1,000 naira. So we end up prescribing poor medication like chloroquine, like quinine, things that they are not using again, just to ensure that we don't end up prescribing ACT. And for the people that knows what ACT is the popular artemisinin, dihydroartemisinin, piperaquine, the ones that we use, the Amala, what again, this popular one in Nigeria, I've forgotten those names, those common one that we used to use, those are the ACT, but they call Quartem, yeah, those popular ones, they are all the same thing, those are the branded name. So they cost something like 500 to 1,000 naira. So because they cost so much, we try to avoid them. While I was in that hospital in Kaduna and some even hospital in Abuja, for every patient I see, the only thing I have to prescribe is chloroquine. Guess what? This is medication that is outdated for general use, unless if somebody's having a severe malaria. Yeah, so in our environment, because of the side effect that chloroquine has, it could make baby have seizure and all that. We are being advised to stay away from chloroquine, except if the patient has severe malaria. But because it's so cheap, you can get chloroquine for 50 naira. I mean, even in the market, it's so cheap. So that is what we resort to, and which is very unfair. So these are the problem. Is the HMO, those are the ones that are rich, very wealthy Nigerians. You will discover that even those that have zero interest in healthcare system, they have 1 or 2 HMOs that they're also controlling, because they get the money from the government, but they'll push the private hospitals or even the government to say, we can't afford to pay you more than this. So whatever care you want to provide, you're on your own if it goes beyond 1,000 naira or it goes beyond 2,000 naira. So if the patient were to have epilepsy, or the patient is seizing or have a severe problem, everything still has to be solved within 1,000. So these are the things that we need to do, the institutional reform that is mentioned. So by and large, I think he's touched everything in terms of the solution. He's provided, he knows the problem, but I think he has focused more on the solution, which I think that is something that is always missing, whenever we are having this kind of robust discussion. So we thank you, Mr. Chairman, for giving us such an insightful solution to our problem. So I can see some few hands up. I'm not sure whether it's Prince or Barrister Elias that first. Oh, yeah, Prince. Okay, thank you, Mr. Chairman. So Prince, I will allow you to have the floor. 5 minutes, please.
All right, thank you very much, Dr. Mubarak. Let me appreciate the presenter for that wonderful presentation. That was awesome. Now, I wanted to ask, I think Dr. Ahmed already addressed this. I wanted to ask that if it's only the responsibility of the government to improve healthcare, but we talked about NGO, UNICEF, civil society, and WHO. Now, my question is about that brain drain. I think we've not been able to elaborate properly on that, or if there's something I'm missing. Now, my question is that how can we convert brain drain to brain gain in Nigeria? Now, we understand the fact that Nigeria is losing most of our talented professionals, not only medical doctors, we also have engineers living in the country now. Now, do we now convert this brain drain to brain gain in such a way that we are not always at the losing end of this issue? Thank you.
Yeah, thank you, Prince, for your question. Just for us to be a bit more organized, I think I will just allow other people to comment, then we can take the question once and for all. Yeah, I'd wanted addressing that. It's part of those things I want to do when I'm having my second go. So that's one of the good thing about reserving some of your comment to the later part, so that we just at one point solve the whole thing. So I will allow, I'll be using this medium to invite our barrister Elias.
Okay. Thank you very much. Good evening, everyone. I thank the presenter, Edime, for the wonderful job, and your mentor also, Dr. Ahmed Abdulkarim, also the moderator as well, Dr. Mubarak. My contribution will be in two directions. One aspect is the HMO that you mentioned, and the other aspect is the brain drain. For HMO, I had an experience from the private sector, which is different from the government sector. I worked for a firm in Lagos where the employer subscribed to the HMO and provided health care service access to the employees. And I think that to a large extent, that platform worked really well for, especially for my family, because we had our first daughter in a top hospital in Ikoyi, Lagos, where if we were not on that HMO, it would have cost us a fortune to, do some of the things we did. And I was made to understand that that was because our employer also paid so much on the HMO package, because it has something like a gold, silver, diamond, and all sorts of different code names for the packages that were available, where by how much more your employer paid determined how much more access you had to the healthcare services. So what did I take from that? What I took away from that is that it is still possible to achieve these things if we are serious with funding and the rest of the other items that have been mentioned before. But private sector seems to be doing better than our public sector, because people that call the shots in the private sector are calling it based on merit. Your employer is not likely to keep you on the employment if you are not putting in inputs, if you are not meeting up your target, you're not performing right. The HMO is not likely to attend to the employees if the employers are not paying, right? So, but they are paying, and everything is then moving forward on the basis that everyone plays their part the way that they should. So in the public sector, there's no way, there's no principle why the HMO system shouldn't also work as well, even better, because government has more resources at their disposal to be able to determine so much things about, one, what we call distributive justice, is when you have certain items to distribute, who is entitled to what. So are you distributing that item to those that do not need it, when those that are in need are actually underserved, or are you distributing it according to equitable principles? Right. So I think that's attending to those issues. HMO, from the private sector experience, appears to be a system whereby government can reach more people to have access to healthcare system if it is fully funded and well monitored, the same way that the private sector employers have been able to monitor it. So for brain drain, I would go back to the illustration. Maybe that might in part answer Prince's question on brain drain. So how do we convert it to brain gain? One thing we must realize is that we are now living in a global village where opportunities that are created in any country will attract the suitable talent for it. And the sooner we realize that, the better. So that it goes back to the illustration of my friend who studied political science in the University of Ilorin. He said that international or foreign relations is like a highway. So when you bring out your car to drive it on the highway, you must take care of things that can cause hiccups on your journey. That if you don't, by the time you then get to the highway and your car breaks down, that's when you realize that other people will not stop their own journey because of you. They will keep moving on. If you see anybody that even waves their hand to greet you, oh, sorry, yeah, oh, and they move on, you should thank your stars, because some people will not even stop at all, and they'll just be moving on and will not care about it. In fact, some people will be angry that you are constituting nuisance because you are now disrupting the flow of the traffic for them without disrupting them. So what am I saying? So if you have a country or some countries that continue to create opportunities for talent, they will continue to attract those talents from anywhere the talents are. So if we want to convert brain drain into brain gain, all that we need to do is to sit down and create the opportunities that can attract the right kind of professionals that we want. So that, and that, to be honest, in a global village, doesn't mean that if doctors are paid well in Nigeria today, nobody will travel again. No, That's not the way that a global village works. The way it works is that people will continue to travel, they will continue to explore and seek for opportunities in different countries. But the question is, are you also having people coming to Nigeria from those other countries or from other countries coming to come and explore? The answer is no. We are only pushing out. There's no analysis or data available to show that the way that professionals are leaving Nigeria, other professionals are also coming into Nigeria as well, which is why it now become a problem. But if you create opportunities that attract talent, you will still find some Nigerians who don't want to live in Nigeria and they want to go and seek opportunities somewhere else. But what you then find is that you find many Nigerians staying, and you also find many people from other countries coming into Nigeria to also seek those opportunities that are being, provided, available. That way, the brain drain thing will become a brain gain, because as much as you have many people living, you also have some other people coming from different kind of experiences from various countries to enrich the system. So, but it's one-way traffic now, because for obvious reasons, we can see that those living in Nigeria, they are living for better opportunities in various places. Meanwhile, there's no much better opportunity or attraction to people from other places to come in to better the situation.
Thank you, Barrister, for that wonderful contribution. I think you've summarized the brain gain problem. Yeah, so you mentioned very important point that it's actually a global issue. It's a global problem. Right in the UK, they are losing their own doctors to Australia. They're losing doctors to Canada and even New Zealand and US. So, and this is where 60 to 70% of Nigerian doctors are also running to, and they're also losing their own indigenous doctors, and even some high NGs, internationally trained doctors to other countries. So it's like a continuum. It's not something that could stop. It just depends on opportunity. People will always migrate. The most important thing is you're also providing opportunity for people to come to your site. It's not that people are just leaving only, but at least a good number of people are also coming back to your own hands, so that you can balance the equilibrium. I will still personally talk about the brain gain problem much later, but I would still like to have one or two comments from the other members so that we could just wrap up our contributions on those things. Tawhid, yeah, you can have a go, please.
Hello, good evening, everyone here. So particularly, I need to talk on the area of funding from the government aspect on our healthcare system in Nigeria. Like today, even tonight, I was actually watching the budget sections defense by the Minister of Finance, Budget and National Planning. I was so displeased with what I saw, because I believe with the way our doctors or some other medical aid personnel, the way they are moving out of the countries to other countries, we know that all what our governments are still claiming about is that they are still putting money in this health sector, and they don't want to believe that the problem is actually from them. I watched there is one budget performance review that was actually taking place last week. I was watching. I look at the way other people from different ministries, the way they are looking at how far they have performed in these budget issues. They talk about the health system, they talk about the educational system, ranges to security. But to my displeasure, the way our government are taking things are very, they are not serious about it. And we can see we in Nigeria, we are looking more at from most of our 8%, they are running from this thing. I was at hospital last week. Before you see doctors, because there is no doctors to attend to people's, and this is very serious. That we need to. I don't know how. In this case, what we can do to solve these issues. I don't know. Maybe our governments, they are not actually care about what is happening, all this and that. So we need people to actually increase in sensitization. Let government know that what they are doing that's not actually what can solve the problem. So what I'm saying in essence is that our budgets, if you look at the way government design the budgets and look at the money actually allocated for the health system, if all these resources are properly channeled, I don't think there should be problems in our health system. So thank you.
Thank you, Mr. Tawhid. I think you've made a very important point regarding funding as one of the major problems that we are having. I mean, I don't think there's anyone here that would disagree with you regarding the poor funding. Yeah, but the funding is really poor, but frankly speaking, what we've got, even if we could manage it in a better way, things will have been much better than the way we have it now. Then you did mention there is no key performer index, like you were saying some budget defense a few weeks ago or a couple of days ago, and some of the indices that they were quoting, it did show that we don't actually monitor how these things are being done. I could remember, I think the last proper audit, budget audit that we have in this country was the 2017 budget. Because ideally, the way the system is structured, for every budget that is being released is meant to be audited by the Office of the Auditor, Accountant General, working along with the auditors, just to make sure that those things are actually those money that they were appropriated, those money that were released, they were actually used for those things that they were meant to use for. But because of ICT, because of poor funding, because there are no computers in the offices of Accountant General, when I was watching channels, last year, he was saying the last proper audit that we have in Nigeria was 2017 budget, meaning that I can tell you from 2018 downward, nobody has sat down to say what has actually happened to this money that were being released. And so if nobody is questioning what has happened, you and I we could guess what will happen to the future money that's being released. It means that anybody could steal those money, and before somebody will knock at your door, perhaps you must have had some prostate cancer by that time, and you must have even died by that time, because by the time somebody is knocking at your door 10 years after you were in office or you were already retired, so what kind of accountability are they looking for? Perhaps the files are not even, they're not anywhere to, they can't even find those files anywhere again. Some of those data have been distorted. Some people have died. Some of those people you work with are no longer existing. So it's just difficult to be able to establish corruption in that system. So the last audit that we had, proper audit of our budget we had was 2017. So 2018 downward, we've not had anything till date. Money were being released, money were being spent. Nobody's is going after those figures to say where this money appropriately spent on those things that were meant to spend on. So that's the problem. Funding is the problem on one hand, but I think the major one is, despite the poor funding, if what is being released is actually appropriated to the purpose, I think what we are having at the moment will be much better. What we'll be getting will be much better than what we're having at the moment. So that's one important thing that I just want to mention. And thank you for that contribution. I think it's very important that you've raised those points. There are still a few things I need to say about it, but like I said, when I'm making my second recap, I'll just touch those things. I don't see any hands. I can't find anybody raising his hand or a hand again, but I would like to mention a few names if they are interested in making one or two contributions. I could see Ms. Baudin a few minutes ago. I'm not sure whether he's still there. It does look like he has disappeared. I would have loved him to make some comments. He's a final year medical student of Obafemi Awolowo University, and is also a brother to all of us here. Do we have any other member that wants to make comment before I allow the board chairman to have a second go? Do we have any other persons that wants to make comments? No, medicine. Yeah, I think you want to have a second go, so then I'll wrap up my own thoughts.
Yes, thank you very much. Our time is fast spent, so I will just be very quick to just summarize things. So people have made very brilliant submission, and I thank you for your enthusiasm about this topic. So Barrister Ilya said something about HMOs and the gold, silver, bronze packages and stuff like that. And that's a private firm. The private firms, the richer the firm is, the more appropriate or standard the kind of healthcare coverage that the staff gets. You understand? And that's like the microcosm of what we expect in the Nigeria sector. So the Nigerian government is supposed to be to be overseeing the welfare of the citizens, and making sure that this is obtainable. And they really do not have to spend this much, I mean, in that package. That's what I mean, because all they need to do is NHS, the insurance scheme to be applicable to the primary health care level. So if we have to take anything from this discussion, if any one of us are in the position of advising anyone to make policy or something, is again to prioritize the primary health care system. Yes, very important. And that's just on paper and not just building, because a senator will just tell you they built 6 primary health care systems in their constituency, but go to that place, goats are sleeping in the primary health care system, no staff at all, nobody is there. And that's deceits, just deceiving ourselves, and it's not working. So again, when we talk about merits, it goes back to monitoring and evaluation. All people in government care is okay. We are employed 500 doctors, 400 nurses or 1,000 nurses, and nobody cares whether they go to work, whether they do the job, whether they are training or retraining, whether they, nobody cares about any of these things. So again, you are not going to have results. And the way people manage the country, the states, and even the local government, nobody will manage their business like that. It will be bankrupt. So, and if we're talking about the healthcare system, again, we go back to institution. The brain drain, brain gain thing, like we've said, it's not only healthcare, it's not peculiar to the healthcare workers, even the engineers and all the talented, the ICTs, the data guys, everybody is leaving the country. If you've got the talent and there's opportunity for you somewhere else, you live. So two ways I would say, to convert it to bring it, in some countries, when you give them, when for every Nigerian that you see providing service to other countries, wherever they are, there's a particular remuneration that goes back to the coffin of the government, and they can have this discussion, this bilateral discussion, government to government level, such that because the amount of money spent in training a single medical doctor is not a joke. So medical education and other education, like education generally, is heavily subsidized. For you to become a chemical engineer in Nigeria, you just go to a federal university, spend a token, you come out with your certificate, and you're able to work anywhere in the world. Same thing, a medical doctor, a civil engineer, and a nurse, and every other professional. So this is every subsidy. So if you're providing this labor to other countries or other economy, then there should be a discussion, a roundtable discussion on how to get something out of that, because it's your labor. And I think they are getting something. I'm not sure now. So I won't be very affirmative about that. So that's one. Number two is talking about the healthcare system now. If you subsidize this education this much, if it's a private-owned business, for instance, you subsidize this education this much after the NYSC, it's not too much for the government to say you can go wherever you want, but you serve within the country for 5 years. You understand? Either in training or in primary healthcare system or something. This model is already being used in the northern Nigeria, where governments send them to school and even pay them while they are students. And after that, they have to work within the state. That's the state government. They have to work for the state government for about 5 years or 2 years. And after then, they are free. They can stay with the state government if they want, and they can decide to go wherever they want. And for a long time, a lot of them end up staying with the state government because their welfareism is taken care of. They enjoy the job. They feel secured, and life continues. So this model can be used at the national level, such that at least you know that for the next 5 years, you have yourself covered, even if they would go. But you can even do better by incentivizing them such that you make sure that infrastructures are available, you make sure the salaries are competitive, and and the working environment is actually also secure. Because like we said, health does not occur on its own. And majority of people, if you ask them why they live, the remuneration will be part of it, but security of life and property is another very important aspect. This country is not safe. You understand? A doctor left his place of work. He has a private hospital somewhere in the north. He went back home. A friend of mine, this is not just somebody from nowhere, a friend of mine, he went back home, got back, somebody followed him home, handmaid, and shot him down right there and then. How do you want to live with that? How do you want to live with that? So the security of life and property is not there, and then accountability and transparency. So NGOs, civil society organization can also help government. If funds are appropriated for a particular thing, there should be people that actually look into it. Are this money actually being used for what they are supposed to be used for? Suit, for instance, they follow the budget, the one that goes to a particular state, and see how the state government are being used. If a project is approved to construct something, they see how it is being used, and then they provide their own report of it to the populace. And that has actually put governments on their toes. So Champions Education Foundation might take that part too, especially for education. Monies are provided for education, might start on the state level, maybe Kwara State, for instance, and then go maybe up to national level over time, such that if money are actually appropriated for a particular thing in the budget, are they being used for what is it? Even though we are complaining they are underfunded, but even the little that are budgeted for it, are they being used appropriately? And I think if many other organizations do this and we increase the awareness such that government knows that some people are watching the back, maybe they will be made to do better. Thank you very much.
Thank you, Mr. Chairman, for the wonderful contributions. You've mentioned a lot of things. I think you've addressed some of the problems as to why people are leaving the country and the possible solutions. You also made mention of the HMO thing. Yeah, I also had a personal experience. I think Barrister Elias, the HMO, they actually ranked, because I remember while I was working in Abuja, if you want to choose HMOs, there are some HMOs, e.g. Zenith. I don't know whether you've heard about Zenith before. Zenith, the amount of money they collect from which the firm or any private sector that wants to use them is actually very huge. And by so doing, the kind of money that they can also deploy into the pocket of those private hospital is also very huge. So say for instance, it takes an average of 1 million naira to do a cesarean section. Zenith can afford to clear that bill, whereas there are some, I would say, useless HMOs that even a cesarean section that costs 150,000 naira, they are not going to, they won't afford it. They will say that no, they can't pay that private hospital. So therefore, that has to come from the pocket of the individual, that's registered with the HMO. So there is no proper scrutiny in that sector. I think that's the problem with the HMO system. There is no proper. Oh, yeah, okay, yeah. I think there's one more person that is raising his hands up. I was already giving my own comment and all that. Okay, yeah, because I would like my comment to be at the later part of this presentation, so that because our time is fast spent, so that we could just once and for all addressed all the points that people have raised. I think Dr. Ahmed Yahman is raising his, okay, all right, yeah. Alent is not raising his hand, yeah, sorry, pardon me for that. I thought Dr. Ahmed Yahman, are you raising your hand? Do you want to contribute?
That's raising my hand. I think most of the points I have, or some comments I have been made by other speakers.
Brilliant.
Thank you very much.
Right. Well noted. Thank you for that. I mean, for that short remark. It just shows that we are trailblazers in this foundation, and we have wonderful minds here and there for us to have, find a way of addressing almost all the gray areas on this huge topic, because to be honest, the topic is quite huge, so if we've mentioned the very important things on those things. I think that's a very positive remark. Going back to where I was before, what are the common things that people have mentioned as to and why they are leaving the country? Number one, poor remuneration. I won't shy away from it. The money that is being paid to a doctor in Nigeria could not even be paid to some cleaners in order climb, and that's contributes to a lot of reasons why many people are leaving the country. The remuneration is so poor. An average Nigerian doctor, a fresh house officer, is not even earning up to £300. You can imagine that's like $350, $400. What will you do in the current world that we are in? With $400, it's barely enough to cater for yourself, let alone your family. So that's a major problem, and that's what now made like a very huge blow on this is the rising inflation and poor purchasing power of Naira. Before now, just barely a year ago, a pound is being exchanged for 460, 500 per Naira. But today, that's 500 Naira, sorry, for a pound. But now it's sometimes around 2 weeks ago, it was around 910, 920. And as I'm speaking, it's around 890 Naira per pound. That's a disaster. You can just imagine. So meaning that if you manage to get 1,000 pounds anywhere, it's almost equivalent to 890,000 Naira. And to put things into proper perspective, a return ticket from Port Harcourt to Ilorin, as I'm speaking, is close to 150,000 Naira. I mean, as I'm speaking, you just one go ticket is 150,000, and a return ticket from Port Harcourt to Ilorin is 250,000. I had a relative that wanted to make a journey between Ilorin to Port Harcourt just barely last week, and he told me that he had to cover 350,000. Meaning, as a Nigerian doctor, a house officer, you can't even imagine yourself going for a short vacation between Ilorin to Port Harcourt unless you have to cover at least a month of your salary, not to talk about where you sleep or what you feed yourself. We can see, to put things into perspective, our remuneration is really, our salary is really, really poor. And people have mentioned other things like huge workload. I've seen situations, I don't know whether some of us have worked in hospital settings before. You will see one particular junior doctor covering the units for a month, back-to-back calls. When we say call means that you have to sleep from say 7 p.m. You have to cover that unit from 7 p.m. at night to 7 a.m. in the morning or 8 a.m. in the morning until you get a capable hand to take over from you. And if you are very unfortunate, you didn't get somebody to turn up in the morning, you could still be there till 10 a.m. in that morning, and you will be expected to come back 7 p.m. that same day to continue that work. So we've seen situations in which for 3 months, 3-month rota, one person, I think the name I saw then was Dr. Ahmed. I think Ahmed are very powerful people. When I saw the rota, it's just Ahmed for 3 months. And I can tell you, even while we were there as a student, we've had such situation. I remember my rotation in orthopedics surgery. We have had only one registrar. So apparently it has to be on call every time. Sometimes there'll be emergency surgery in the middle of the night, and sometimes, and even those that are in neurosurgery, is that poor. If you were to be on call every night, all day, all night, sorry, for 1 month in the UK, then I can imagine how much you go home. One is not healthy. They will not even allow you to do it because they would think, it's not, how will I call it? It's not brain friendly. There's something they call brain fugue, in which there will be a point that you won't even be able to think again, and you're putting both patient and yourself at risk. So there's no way you can do back-to-back more than 72 hours call in the UK. Nobody will allow you to do night more than 3 days at a stretch. And if you manage to do 3 nights as a stretch, it's compulsory for you to have 48 hours rest. Not 48 hours of playing night, 48 hours of not coming to the hospital. They don't even want to see you in the hospital at all. And if you dare come and take any shift, then they will raise a concern and send something to the GMC to say this doctor is not safe. You can imagine. And this is something somebody is doing for 3 months in another client. So workload is another thing people have said. The other thing people have mentioned is bullying. It's more or less like slave masters training. That's the kind of training condition we have in Nigeria, in which you're more or less like a slave to your master. Your master can determine to fail you. It can determine to pass you, depending on how you feel about, how he feels about you. I've seen situations in which senior registrar, that's somebody that is almost becoming a consultant, a specialist, will be the driver of the consultant. He will be the one to go and pick the consultant kids in school. It will be, so it's just more or less like you're trying to say, yes, sir, yes, sir, yes, sir, just for you to pass. Here in the UK, or even in other senior clients, nobody cares about you. Do your work. I have got a supervisor, I'm in training. My supervisor doesn't care about me. He doesn't know where I live. He doesn't even want to know. The most important thing is, gentlemen, you come to work and you do your job. So long you do your job, you're not going to have any problem with them. Nobody cares about you doing anything for them. So that's very important. But in Nigeria, there's a lot of bullying at work and all that. And that's one of the reasons why somebody like me, while I was training, I said I will never train in Nigeria because of bullying. Not even because of remuneration. Remuneration was like the third or fourth thing that came to it, because at that time, 2015, Naira wasn't actually bad. I mean, people were earning something like almost 1,500 pounds, even in Nigeria, if you convert pounds to Naira at that particular exchange rate. But if you see the level of bullying and all that, even obtainable as at 2015, 2016, I'm sure any reasonable person wouldn't want to be subjected to such thing. I've seen situations in which a married person, a married senior registrar, was being told by our consultant to say, who even managed to marry this one? I mean, who married this one? Imagine in front of younger doctors, and somebody is pointing to a very senior person, and you're telling him that who married this idiot. That means he's referring to the senior registrar as an idiot in front of a junior one. We were just barely 25, 24 years of age at that time. This man is close to 40s. So that is bullying. You dare not do that in this UK. If you do that in senior client, your job is gone, irrespective of who you are. Even if you are Rishi Sunak, you're the prime minister. If you say something like that to somebody, you bully that person, and I can tell you that person will lose his job within 24 hours. So that's very important. So people don't respect what you do. They don't value you as a teammate. And it's one of the reasons why people are leaving the country. Other things people have cited, like what the board chairman are saying, poor training. How many mini access surgery do we do in Nigeria? The keyhole surgery that we say we do is like bread and butter here. This is something that almost an ST1 or CT1 trainee can do. So the training condition is poor. You will see the medications are not too good. The equipment are obsolete. You know, how will I call it? Even the capacity itself, you know, we have one professor taking care of the whole department, which is not enough. One professor to like 4 or 5 senior registrars. If you look at that ratio, the ratio is very poor. That is not the same thing that is obtainable in the UK. In the UK, we expect 1 trainer to 1 trainee, 1-to-1 mapping. So somebody is looking after you, somebody is looking after your progress, somebody is looking after your portfolio, somebody is making sure that you're doing the right thing. And say, for instance, to put things on that perspective, before you get signed off for you to say, okay, you can replace hip in the UK, you must have done more than 300 hip replacement. Done, not to watch, not look. You must have done hip replacement, 300 hip replacement before you can be signed off to be competent enough, like for somebody to say, oh, this man is competent or is safe to carry out this procedure. Total hip replacement, you must have replaced 300 hips. In Nigeria, you could finish to be an orthopedic surgeon without doing 1 total hip replacement. You can see, while I was in Udut that time, I could remember the orthopedic surgeon that is there is now a professor. He was celebrating the first total hip replacement that was carried out in that place. What we normally do is the carpenter work. Femoral fracture, you replace it. All these are our intramedullary nailing. You have a fracture with your lower leg, you replace it. But to say somebody wants to replace the hip by using all the modern stuff and all that is not existent. And I can tell you, even in Sokoto today, that might have been the last one that they ever did. I won't be surprised, you know? So why would you call yourself an orthopedic surgeon when you cannot replace a hip? That's one of the very basic things that they do here, not to talk of other complex surgery. So the quality of that training is not there. I was reading an article that was saying almost 500,000 heart procedures and heart surgeries were done alone in this UK in 2018. 500,000 for which population of almost 60 million, 70 million, 500,000. That's close to 1 million procedures, heart procedures alone were carried out in this place. So you can imagine the level of specialists and all that. So these are things that people hear that made them to say, no, they are not staying in Nigeria. After all, the remuneration is not good. After all, people are not encouraged because there's a lot of bullying at work. After all, like Medicine has said, somebody can just wake up, one mental health patient, somebody that is psychotic, somebody that has a problem with his brain can just wake up and say he doesn't like this person, and he will just gun you down and nothing happens. I know this friend is talking about, I can remember the case, I think 2 to 3 years ago, till now, nothing happened. This guy was shot dead, I think somewhere in Zamfara or something like that, somewhere around that northwestern region. No, Niger, I think precisely, Niger. He was shot dead. There was also another case of
Niger State.
Yes, yeah, thank you. Niger State, yeah. There was also another scenario in Zamfara. One very notable gynecologist, obstetrician and gynecologist that was killed around that time. Nothing happened. Those people leave family behind, they leave loved ones behind, and nothing will happen. Nobody pays them for.
And just 3 days ago.
Yeah. Yeah, yes, that's another new one. Yeah, just 3 days ago, somewhere in Delta, another young man was, how many more can we say? And these are the ones that find their way into even the press. There are many other things that happens, without anyone saying anything about it. So I've made mention of some of those things that some of the reasons why people are leaving. And like Barrister Elias has said, it's a global thing. People leave every time. But the most important thing, as UK is losing doctors to the places like Canada, New Zealand, places like Australia, they have enough people from Africa, trying to replace them. They have people from Caribbean trying to replace them. They have people from Asian, the Pakistanis, the Indians trying to replace. So there's a bit of balance. Day to day, this state that they're struggling, but when you talk about struggle has category. Their way of struggling, their own level of struggling is different from our own level of struggling. So like Barrister Elias said, it's about striking the balance. You really heard about an Indian saying he wants to come and practice in Nigeria, or any Haitian or any Caribbean saying I want to practice in Nigeria. I can bet you there is no place that is as good as home. I personally, if they can improve some of these things, remuneration is the last thing, and maybe they can pay me 50 or 200% more of what they were paying in Nigeria. I will stay in Nigeria. I will gladly take it. If my place can be secured, if I can't get to treat my people, why not? Why will I be running after some white folks when my own people are struggling at home? Sometimes I look at myself and I pity myself. Somebody is dying somewhere, I'm there saving their life, but there's nobody looking after my own mother at home. Nobody's looking after my father. Nobody's looking after my aunties. There should be some satisfaction, that comes to you, even if you're not well paid. But there's this satisfaction that comes with this. So I'm helping my people, I'm treating my people, and all that. I can imagine myself working in Lorry, how gratifying it's going to be, how easy is it going to be? Because I'm going to speak in my local language. I'm going to communicate with them at almost like friendship level, all those things for those people that understand Yoruba. And this is exactly what's obtainable in the UK. Those local lads, they find work very easy, because some of these people, they know them, they agree with them and all that, they grew up with them and all that. So when they are communicating with them, even though you're speaking the same English, you will know that there's that fluency, there's that rapport, in that management, which is very essential. When you talk to patients at a very basic level, man-to-man level, it eases things up. It has a way of making them feel better. It has some placebo effect, even without giving them any medication, because they feel safe. They feel this guy know them. They feel, I'm in a very safe hand, and that goes a long way in their well-being. And like Medicine has already said, it's beyond physical problem. Mental health is something very important. Physical health is as important as physical health is. Mental health is also very important. So when you're managing patients, we're not only managing their pain, we're not only managing their physical part, you're also creating rapport and working on their brain to make them feel safe. And if you could, take the two hand in hand, you will see that you will be acknowledged as a very good doctor. So I think I've mentioned that. I've talked the HMO thing. I think it depends on the HMO. HMOs like Zenith, they're very, very wonderful, but they charge. Barrister Elias, if you go to the finance sector of that firm, you will discover that they're actually paying a huge sum of money, to be on the register of that Zenith, because Zenith collects a lot of money. I think as at the last time, I think the least something that they collect per year is close to 200,000 or something like that. At the least package, they have package that is more than £1 million. out of all those bronze, silver, and something that we mentioned. So they actually charge their clients huge sum of money. And because of that, they are able to deliver quality services to their clients, which is very good. So there's a lot of issues happening around the NHIS HMO something, but it's not something that we cannot tackle. We're just being unserious. That's just the reality. In Nigeria, all we need to do is just to sit down. Like somebody has said, somebody has read the paperwork, has read the white paper, and he said it's actually a very good initiative. Those things that are written in there are very, very good, lofty ideas. But the problem is, are we implementing these ideas? No, that's where the problem is. And what can we do about it? We all know what we should do about it. Educate individual, educate electorate. We are given another opportunity to elect credible leaders come 2023 in the next 50 or something days. But if you look at the kind of I would like to call it the turnout I saw in Kano today, and other part of the country, you discover that even those people that are being victimized, they do not even realize that they are being victimized, or probably the poverty stuff is taking a toll on them. So they are being victimized, but because of what they will eat or what they will the 5,000 they will give them, they still come out and still vote en masse for the perpetrators. So we call it a Stockholm syndrome, in which you're being victimized at the same time you still want the perpetrators, to continue to victimize. It's just a shame. So we need to educate ourselves. We need to enlighten people. We need to open people's eyes. We need to press the government more. What is happening on social media now is unprecedented in this country, which is a good thing. Before now, what people used to campaign is agbado, things like Gari and all that, but it's becoming unacceptable. And you can see when they started with Agbado campaign and all that now, in the last couple of months, nobody has mentioned Agbado again, because the electorate have shown that, no, we no longer continue to take this. Even though those that are making the noise, those people that are forcing these people to change are actually infinitesimal, when that day comes, because that's the problem. When you look at Twitter, you will discover that we have less than 5 million Nigerians on Twitter. What's the population? More than 200 million. Perhaps we don't even know our population. How many registered voters? 89 million registered voters, 90 million registered voters. So we have 5 million people speaking for 90 million. At the end of the day, even the whole 5 million, they say they're going to vote for one man, we still have 85 that can still decide who wins. Whatever vote you bring from the whole Southeast region, I used to tell people, one Kano and Lagos vote cannot turn it, which is a shame. And that's the kind of system we are working. It's about number. So even an imbecile has the same votes as a professor. And that is why those people that decide to create this system, they put some caveats to it so that imbeciles will not dictate for them. For instance, the US system now, even though number counts, but what actually matters, we and I know it. There are those intelligence ones that actually dictates who wins. For instance, in 2016, that was this election between Trump and Clinton, Hillary Clinton. Hillary, by virtue of numbers, actually won that election. But we and I know that we have these people that we call the electoral, what do they call them in the US? They call them electoral something. Sorry, it has skipped my mind now. But we call them electoral.
Is it electoral college?
Yes, the electoral college system. Yes. So those are the ones that will actually indirectly dictate who wins. So she got the number, but Trump has more electoral college people behind him. And eventually, what determines who wins is the electoral college something. So that is the kind of system that runs over there. And these are still the ones that will be preaching democracy to us. But if you look at them, they've managed to redefine their own democracy so that imbeciles will not dictate who wins. But in Nigeria, it's about the number. It doesn't matter who votes. I've got one vote, you've got one vote, just like anyone else. So if you manage to marshal the market women, even the mentally challenged individuals to vote for you, so long you get the numbers, then you will be declared the winner, which is a shame. In the UK system, they use parliamentary system. We and I know that for you to even emerge, just unlike our own primary system, that somebody can just bribe a few number of people and you become the flag bearer. And we and I will now be running after the flag bearer. Whereas where the problem is actually the primaries, those primaries that have been conducted. That is where the problem is. we need to change our electoral system, because it's those people that are presented during the premise that you and I have to now decide on. So if they presented nonsense people, we've got very good people in the APC, but at the end of the day, we know the person that eventually emerged, somebody that has a questionable character. We can't say he has any problem. Somebody that people are querying his health and all that, he has a challenge and all that. I, as a person, I think he's a very good person in terms of what he has done in the past, but you can't say when it comes to his health perspective and all that, those things are questionable at the moment. This is not a political forum, so we don't like to talk about it. So when you go to the PDP candidate, you also have his own things that people are questioning. If you go to the Labour Party candidate, there are a lot of things that people are questioning, and there are better individuals that could actually come out from this platform. But from the primary level, they block those things. So you and I will just have to decide on those few individuals that presented through the primaries. So where the problem is actually the primaries, not the whole election itself. But how can we change these things? Educate the masses, let them know their right, put pressure, like the way Champions Education has started trying to put pressure, release things in the media, let electorate, open the eyes of electorate to things and all that, and what the likes of Sarah and the likes have been doing in the last couple of years. I think it has put a lot of pressure on our leaders, and I think it's the right thing to do. I mean, we can keep talking about these things from now till morning, and we won't stop. I think I've been able to address those things I want to address, the reason why we are losing a lot of people and what we need to do. If we want to do those things, we need to improve the remuneration, work on our working condition in terms of stop bullying people, work on our workload. Our rota is absolute rubbish. Nobody wants to work in that kind of environment. We need to improve the working environment. And if you can adjust some of these things, I think even if the numeration is a little bit improved, we will see a lot of people. At least if we don't have enough people coming down, majority of people will not be leaving the sector, which is very important. Prior to 2016, 2017, we don't have huge number of people leaving Nigeria like we have now. So I will be drawing the curtain on that note. Yeah, can I have somebody to give us the vote of thanks and closing remark? Yeah, so I will be having one person for vote of thanks, then another one for closing remark today. Barrister Elias, I would like you to give us a vote of thanks, and maybe if you want to pass any short comment, that's fine. You can chip it in there. Our time is fast spent. And of course, our honorable board chairman, you will be doing the closing. Oh, Dr. Ahmed Yaman, please. You will be giving us the closing remark. Is that okay? Thank you. Over to you.
Yes, thank you very much,
Barrister,
Dr. Mubarak. Good evening once again, everyone. Vote of thanks can be given in 3 words, and it is thank you all.
Thank you. Dr. Ahmed, over to you, please. Closing remark and possibly your side comments, if you want.
Okay, thank you very much for this opportunity. I will try and make it very brief. It's a pleasure to be among these beautiful minds, and you made a lot of beautiful points, all of which are valid. I'd like to mention some of us are still here. We're around. We'll take care of your mother, your sister, your aunties. We're around to take care of your family members. Like I said, I also worked in Sokoto, and currently I'm in Ilorin. When you spoke, as if you were just like talking about me. So yeah, so I was just smiling all through. So I are mostly problem solved. Like most of these problems have been identified. I believe the brain drain would eventually become a brain gain by God's grace. Like with these collaborative efforts, identifying this problem. Basically, we've identified a lot of problems here. And I believe we are great minds. So the future is bright. I believe things shall get better. We can't lose hope on Nigeria. We can't lose hope on our health system. With collaboration with you guys over there, some of us here, I believe a lot can be achieved by God's grace. Thank you very much, everyone, for coming around, and we hope this will not be the last. Thank you very much. Thank you.
Yeah, thank you, Dr. Ahmed, for your wonderful remarks. We really appreciate you. I mean, we want you to be, we do almost every month or so every now and then, let's say averagely a month, we do hold this kind of program, and we would like you to join us every now and then. Are you do you know our CEF assembly page on WhatsApp?
No, I don't. This is my first time joining.
I will
this,
add him. I got his number. I'll add him.
We would like to have to be a pleasure to have a wonderful mind like you, Ms. Host. Thank you for your wonderful contribution. We hope to catch up with you much later on other things too. Thank you. Yeah, do we have any other comments from anyone? All right. On these notes, I also want to say thank you for the presenter. Thank you to our mentor, our board chairman. Thank you, Barrister Elias. Thank you, everyone that has made wonderful contributions today, Dr. Ahmed, Tawheed, our very own Taiba Sarafadi, Nafisa Folari. I can keep mentioning everyone. Prince, I mustn't forget Prince and everyone that is here present. I really appreciate your time. It's not easy, to be this dedicated. I hope sometimes in the nearest future, in the nearest days, we'll catch up to discuss a much important topic. Thank you for being present tonight. Yeah, thanks.
Yeah, thank you very much. Good night.
Good night. Bye.
Good night. Bye.